Hi, good afternoon, or is it? I'm sure by now it's late afternoon in Ghana. I trust that you've really been enjoying yourselves and learning, and that this school has really enriched you, even in your endeavors to move forward as young neuroscientists. So I want to talk about two topics: drug metabolism, and then I'll finish this talk by saying a little bit about drug interactions. So basically, my learning objectives, forgive me for the two ends there. By the end of this module, this lecture, at least participants must be able to define what metabolism is with respect to drugs, to explain the purpose of metabolism, to define what a prodrug is, to state the two phases of of the drug metabolic process in the liver, to list the major organs involved in drug metabolism, to discuss factors that influence drug metabolism, and discuss the implications of metabolism in drug interactions, to explain how drug interactions can emanate from absorption, distribution, as well as elimination, together with drug metabolism. So I will pitch this lesson at a pretty medium to low level. We will not go into in-depth issues, but we want to concentrate on the broader issues which are important for us when we are doing the work that we will be doing with regards to the experimentation we are carrying out. So what is metabolism or drug metabolism? So drug metabolism can be defined as a process by which the body breaks down drugs, usually to inactive metabolites, but as we shall see, sometimes it can break these drugs to active metabolites. And this is done through the action of enzymes which are found within the body, largely within the liver. So basically, the body views and treats most drugs that enter into it as foreign substances. And the word that we would use for foreign substances, which I'm sure most biochemists in here would be aware of, is the word xenobiotics. So whenever a drug substance comes into the body views it as a foreign substance. And the moment that the body views it as a foreign substance, it wants to eliminate it. So what metabolism does is that it alters the structure of these drugs. And basically what the body is trying to do is one of two things. Number one, it's in the hope that, and this hope is used very loosely, that the activity of the drug or the chemical which has come into the body is reduced. But like I said earlier, metabolism does not necessarily lead to a reduction in activity or a termination of activity. And then the second thing, that the metabolites are actually the products of metabolism, that the metabolites become less lipid soluble and therefore are more readily eliminated from the body. So the two reasons: number one, to try and inactivate the drug, and secondly, to make the metabolites or the broken up drug much easier to eliminate. And the body basically does that by making the metabolites more water soluble, or more water loving, or more hydrophilic and less hydrophobic. Because if you've got a hydrophobic drug, it tends to want to stay within the body, into the tissues and other places like that. So metabolism basically is trying to turn a hydrophilic, eh, let me say this again, a hydrophobic or a lipophilic drug into a hydrophilic or a lipophobic drug, if I can put it that way. So the results of metabolism are that some xenobiotics are activated into toxic metabolites through metabolism. And this is within perhaps the domain of toxicology. And we shall see one or two examples as we go through this. And some other xenobiotics are actually detoxified. And whenever we talk about metabolism, there's always the potential for interactions which can occur because of what is called the cytochrome P450 um, enzyme system, which can either be inhibited or induced. But we'll talk a bit more about this in slides um, to come. So the liver, I saw this and I just fell in love with it. The liver is the main organ which is involved in breaking down of drugs or in metabolism of drugs. And the liver is well suited because everything that we take orally after it leaves the gastrointestinal tract would go to the liver. And when it goes to the liver, metabolism occurs, and this process is what is referred to as first pass metabolism. So you get drugs which come into the body and are broken down before they can actually get to the target sites through the liver, through this process of first pass metabolism. And several efforts have been made in the past to try and surpass first pass metabolism. For example, giving some drugs sublingually, maybe some also being given through the inhalation route, bypasses the first pass metabolic route. But other organs are also involved in the metabolism of medicines and drugs, but not to as much an extent as the liver. And these include the kidneys, the lungs, the GIT mucosa, as well as the skin, which can also be involved in metabolism of medicines or drugs. With regards to drug metabolism, um, the liver metabolizes molecules in two phases. There's what is called phase one metabolism, and there's what is called phase two drug metabolism. So after we've taken a drug and it comes into our body, when it moves into the liver, the first metabolic processes that ordinarily would occur would be the phase one metabolism. And basically, through this pathway, the structure of the molecule is altered ordinarily by the process of oxidation. In fact, most first one metabolic processes use oxidation. And this is done by what is called the mixed function oxidase system. Mixed function oxidase system, particularly a family of enzymes called the cytochrome P450 family. And when we're talking about enzyme induction and enzyme inhibition, we'll be largely talking about the cytochrome P450 family of enzymes, which are the ones which are responsible for most of the phase one metabolism. So we said it's oxidation. And then what oxidation does is that ordinarily the metabolites may retain biological activity, and there is a large number of drugs which are actually metabolites which have got the same activity or probably a bit less, but what then changes would be the half-life. And also through this first pass metabolism you can get formation of some metabolites which are toxic, for example the epoxides. And if you look at the toxic mechanism of paracetamol, it's because of first pass metabolism, which creates what are called imines, which are very reactive species, which then react with cellular components in the body, causing destruction of the liver. So this is an important thing to note, that first pass metabolism can, number one, produce metabolites which retain biological activity, but can also produce metabolites which might have some toxicological consequences or effects. So after the phase one metabolism has been done and oxidation has occurred, what the body then does is to subject this new molecule or the metabolite to what is called phase two metabolism. And phase two metabolism normally entails the addition of a pretty big molecule like glucuronil or sulfate or acetal. So it adds it onto the molecule which has been formed here, the metabolite which has been formed through phase one metabolism. And what this conjugation does is these large polar endogenous molecules like your glucol, I always have difficulty saying that, glucuronil then produce conjugates which are more water soluble. And if you recall from the beginning what we said, that the body is trying to eliminate this compound from its system. So whenever you form something which is water soluble, that's a good thing, because then it means this can be transported through the blood, and it can be transported to the kidneys, and then become more readily eliminated. So whereas we said with phase one metabolism, you get the production of either toxic compounds or metabolites which may still have biological activity. What phase two metabolism does basically is to terminate activity. And then I just put this note here so that I do not forget that the activity of the cytochrome P450, which are the enzymes responsible for most of the interactions that we see in the body, which are related to metabolism. The activity is also dependent on age. The younger young children may not have a system which is fully formed and functional, and therefore the metabolic process might be a bit slower for some particular compounds. And this is also of particular importance even with regards to the preclinical studies that we may be doing, thinking about the metabolism of the compounds that we're dealing with vis-a-vis the age of the animals that we will be using in the experiments that we are doing. So for cytochrome P450 enzymes, they're very young, activity is low, and also as people begin to age, activity also reduces. So this is just something that you also ought to keep at the back of your mind whenever you are doing the experiments that you will be carrying. Okay, so I've been talking about enzyme induction and enzyme inhibition. So basically, these enzymes which break down drugs that come into your body can be induced, meaning that the number, or not the number, or let's say the amount of enzymes available for metabolism can actually be increased. And there are certain conditions and certain chemicals that can lead to that. For example, drugs like your barbiturates can actually lead to enzyme induction. And what enzyme induction will do is that it will increase, the breakdown of the drug itself, as well as other drugs that may be taken concurrently with it. So we've got drugs which can lead to enzyme induction, but we've also got herbs as well. So for those working with extracts, that's also something to bear in mind. You might find that perhaps as you are continuing to give the extract of a prolonged period of time, repeated doses, that perhaps the activity seems to be reducing. And I think Martha talked about tolerance yesterday, and I've got a slide or two to just remind us of these things. And it might be as a result of enzyme induction, which has actually occurred. Some foodstuffs can also cause enzyme induction. Some pollutants like DDT, which is a pesticide, as well as smoking tobacco, can also lead to an increase in enzyme production or enzyme induction. The implications of enzyme induction. I've already started saying some of them, but just to go through them maybe one by one. So the implications of increasing the number of enzymes, not a number, or the amount of enzymes, or the activity of enzymes from the liver, is that in some instances you can get toxic metabolite concentrations going up. For example, in paracetamol poisoning, the poisoning from paracetamol occurs because of a phase one metabolite, which is an imine. And you will find that in patients or people who, and it's through a particular enzyme, in the particular cytochrome P450 enzyme, I think it's 2D6. So you find that in people who may be heavy smokers, and those who may be heavy drinkers, that the proportion of the active metabolite, or the concentrations of the active metabolites, are actually much higher, and therefore toxicity actually occurs at much lower dose in people with who have taken an overdose of paracetamol. And interestingly, the opposite is true for children. Children are very young children are particularly not really resistant. I don't know the word I'm trying to say, but they do not really suffer from paracetamol poisoning on a milligram per kg basis as adults do. And it's largely because their phase 1 drug metabolic system is not yet fully developed, so they do not produce as much toxic metabolic concentrations. The other thing that could happen is that when you're taking two drugs concurrently, and one of the drugs happens to increase the activity of the cytochrome P450 enzymes or cytochrome P450 enzymes, let's just use that. It could lead to a breakdown of the other drug, and this could lead to treatment failure. For example, people who might be on oral contraceptives and then are given perhaps a drug like, I don't know, phenytoin or phenobarbital for epilepsy, the concentrations of the oral contraceptives could actually be subtherapeutic to such an extent that it is not giving the protection that it's supposed with regards to avoiding pregnancy. So there can be treatment failure. And the treatment failure, moving on, is not really, it's not necessarily concerning the other drugs, but the drug itself, which is an enzyme inducer, can cause a reduction in its own concentrations if the activity of the enzymes of the liver increase. For example, if the anti-epileptic drugs are a classical example, whereby the dose might need to be increased. When you start with a pretty low dose, but you might need to increase it because of their potential to induce cytochrome P450 enzymes. But it might not be all bad sometimes, because there are some compounds, some drugs, which are only activated by metabolism, and we refer to these ones as prodrugs. And in cases where there is enzyme in induction, it might mean that you need less of the prodrug in order for you to get whatever therapeutic effect you want to see in the end. So whenever we're talking about drug induction, although I tended to probably spend more time talking about the negatives, it could either be positive or it could be negative. Even with regards to the prodrug, there's a negative, right? Because it means that if we increase enzyme activity, then the concentrations of the active metabolite could also increase, consequently leading to toxicological effects as well. So that was enzyme induction. But there's also what is called enzyme inhibition, which is basically the opposite of enzyme induction. So with enzyme inhibition, we've got compounds which may inhibit those monooxidase. I keep on stumbling on myself, which would inhibit the cytochrome P450 enzyme system. And what this would do is that it would leave the body in a position where the activity of the drug metabolizing enzymes is actually reduced. And what this would mean is that concentrations of drugs that are taken concurrently with the enzyme inhibitor would increase, and that could actually lead to more serious toxicity. From a toxicological perspective, we tend to be more concerned about enzyme inhibition compared to enzyme induction, except perhaps when we are dealing with prodrugs or protoxins which are activated by the drug metabolizing system. So examples of drugs which would cause enzyme inhibition would be your cimetidine, but you've also got your azoles here. And then you could also have grapefruit juice, which is a very well-known classical example of a food which can cause enzyme inhibition. So the effects can be more profound than those for induction, and this could actually lead to more serious toxicity. So with regards to, I think, issues to do with metabolism, that's what I thought I would just say quickly, being cognizant that, you've been here for how many, 3-4 days, and that this is perhaps one of the last sessions that you are going to be through, and most of you probably are tired. I wanted to keep it nice and short and just major on the things which are more important. But then just to talk a little bit about interactions of drugs and chemicals. And what we'll start by just recap, because the issues that we'll be talking about and the words that I might use are words that you were exposed to. So we'll start with the word or the term potentiation. And potentiation is where a chemical or a drug enhances the effect of another, or where a substance that has no pharmacologic effect or no toxicologic effect by itself increases the pharmacologic or the toxic effect of another drug. Just like this equation. So it would be like 0 plus 1 is equal to 2. For example, when you have a drug like amoxicillin, which is a penicillin, which by itself covers a certain spectra of bacteria that it can kill, but other bacteria are resistant to it. When it is put together with another compound, clavulinic acid, which has got no activity at all, but when they put the two together, the bacteria that amoxicillin then covers becomes much more than the amount or the range that it would cover by itself. And from a toxicological perspective, we've got isopropanol, which by itself is not a liver toxic substance, not hepatotoxic, but when it's taken together with tetrachloromethane, it actually potentiates the liver damage, meaning that the liver injury actually goes up. And then you will recall additive effect. I think Martha talked about this as well, which is basically 1 plus 1 is equal to 2. And this is very important from a drug interactions perspective, because you've got some drugs from a broad perspective which have got actions which are similar. And when you bring them together, the total amount, if I can use that word loosely, amount of the actions is the same as an addition of the two drugs together. For example, the effects of lorazepam and diazepam. So diazepam will be like 1, and lorazepam will be 1. And then we've got synergistic effects, where a combination of 2 or more substances produces a greater toxicity than expected. And here the example which I have is a toxicological one, but it can also be there could be pharmacological examples as well. For example, cigarette smoking carries a certain risk. It must be maybe what was it? I don't know. I said smoking, yeah. 12 times, and then working with asbestos is 5 times the risk, and then the risk of getting lung cancer when somebody smokes and they work with asbestos shoots up to about 60 times. So that's a synergistic effect. And then antagonism is something that we talked about, that Martha talked about yesterday, where one chemical or drug blocks or reduces the effect of another chemical. A classical example would be your atropine and your carbamates working at the muscarinic. And then tolerance, which we in part mentioned earlier, is like an adaptation to repeated doses, where larger doses are actually required to elicit an initial effect. So if you need 2 tablets to get rid of pain, Williams is the pain master to begin with. And then after some time, you now start maybe to need 10 tablets to get rid of the same level of pain. This is what would be required, what would be defined as tolerance. So having said that, and quickly go through the issue of drug. So when you talk of drug interactions or herb interactions or extract interactions, whatever you refer them to, you should know that the extracts that we work with or the compounds that you're working with can either increase or decrease the effects of other herbs or other chemicals or other compounds. And these could be herb interactions, drug herb interactions, drug food interactions, different types of interactions. So, from a broad perspective, when we talk of interactions, there are 2 major groups of interactions that we talk about. They're what are called pharmacokinetic interactions, and I am aware that we've been talking about pharmacokinetics today. So these ones would be concerned about, would involve or emanate from issues to do with absorption, distribution, metabolism, and elimination. And then we've got what are called pharmacodynamic interactions, which have got more to do with the mechanism of action of the drug itself. So, for example, a pharmacodynamic interaction is whereby you've got one compound um, which may have effects pharmacologically, which are the opposite to the other compound, and that's the antagonism that we were talking about. So, you've got one compound which has got effects which are opposite to another compound. Even as we're doing whatever we are doing, this is a pretty an important thing to talk about or to think about with regards to the extracts that we are using in the lab, as well as what we might want to use as our positive or negative control. To say what effects, right, at a pharmacodynamic level might my extract have, or might the other drug that I'm using as a positive or negative control have. And then you can have a pharmacodynamic interaction whereby you have two drugs coming in, um, and it basically leads to either an increase in the pharmacological activity of another drug, or the two drugs coming together have got an additive effect, or the two drugs coming together have got a potentiation effect, or the two drugs coming together have got a synergistic effect. Or it could even be a toxicological effect. For example, this is a plant that we have in Zimbabwe, Securidaca longipendiculata, which contains salicylates. If you take this plant and you're also taking aspirin as well, what you do is you get an additive effect in terms of the toxicological properties, but also even in terms of the pharmacological properties of the two drugs coming in together. Then the pharmacokinetic interactions that we get would be associated with all of the four: absorption, metabolism, distribution, and elimination. For example, looking at the level of absorption, I'm sure there's another slide. So a drug's absorption could be altered by another drug or a compound. And this is an important factor to consider. I have seen student projects where they are administering an extract of interest, and perhaps some other drug which is supposed to be a positive control or something like that. But then, by virtue of the fact that they do not separate the time that they administer the positive control and the time that they administer the extract, the positive control probably is not absorbed because of complexation, and then the results are all messed up. So when you're thinking about interactions from an absorption perspective, we must think the extract that we are taking, what effect is it going to have to other drugs that might be taken together with it? And then we've already talked about metabolism. From a distribution perspective, you can have compounds displacing other compounds from plasma proteins or from plasma tissues. And then from an eliminating perspective, you can have compounds that either increase or decrease elimination of other compounds from the body. Quickly to go through these ones. So you can have drug interactions occurring at the level of the gastrointestinal tract. So if you take two compounds, your extract, and then let's say you also want to feed your animals with aluminium chloride, perhaps to for as a model for Alzheimer's. If you take your extract and you put it at the same time with your aluminium chloride, or you administer your aluminium chloride first, a few seconds later you administer your extract, you might find that perhaps your animals might not develop the neurodegenerative state that you're expecting, because your extract may have within it compounds which could complex with the aluminium chloride that you gave via gavage, and therefore there was no absorption which occurred at all. And now, when it comes to interpretation of results, you're surprised. Why? What is happening? Or maybe you are like, oh, I think my extract really works because the effects of aluminium chloride were reversed. Yet, really, it was a methodological flaw which caused a drug interaction, and none of the aluminium chloride, or maybe a smaller amount of it, was actually absorbed in the end. I hope that makes a bit of sense, because I've seen lots of students faltering on this. And then you can also have compounds which can alter gastrointestinal transit time. For example, atropine, or even if you are dealing with compounds which have got atropine like alkaloids, they can reduce movement of the GI, and that could consequently lead to your drug perhaps being more fully absorbed, depending on where the absorption is taking place, whether it's in the stomach or more in the small intestine. And then this one is something that I think neuroscience students should know about. Monoamine oxidase inhibitors, tyramine, and the cheese storm. And if you don't know about this, please go and read it, because this is something that is supposed to be some knowledge that we have. So I just put here that you should always think about your compound and what you co-administer your compound with. Ask yourself, is it affecting absorption in one way or the other? And sometimes the results that we see are not really very accurate, because some interactions could have happened at this level. And you can get interactions which arise from distribution, where some compounds may displace other compounds from plasma proteins. And a classical example is your sodium valproate and phenytoin, um, which sodium valproate can actually displace a phenytoin from the plasma proteins, or is it the other way around? For this displacement which actually occurs. You can also have displacement of drugs from the tissue or tissue binding. For example, quinidine displaces digoxin from tissue binding sites, increasing the concentration of digoxin in the blood, and this can actually lead to toxicity. So again, something else to think about with regards to what is happening in your body. And well, this information is really largely good when we're thinking about interpreting the results that we have, and we are trying to discuss the results and what could have gone wrong, what could have gone right, what could have caused what. And then I think finally we get interactions which occur at the level of elimination. And these interactions largely can occur because of interference with passive diffusion. I think by now you have gone through excretion of drugs through the kidney, and there's passive diffusion which occurs as you go down the kidney. So you can have drugs which can alter urinary pH, thereby causing an ionization of other drugs, thereby either increasing the elimination of those drugs, or if the drugs become unionized by virtue of changes in pH, it increasing the reabsorption of the drugs back into the circulation. There could also be interference with active transport systems through competition for the active transport sites. And a classical example of this would be your probenecid and your penicillin, but also methotrexate excretion is interfered by aspirin. So that's what I wanted to just talk to you about with regards to metabolism and drug interactions, and things that we should perhaps be thinking about as we are doing our work. And I hope that we managed to get something from it. Like I said, I did not want this to be too exhaustive and too long, but just to give the more important issues that we should have at the front of our heads or at the back of our minds. So that's it from me, and I want to say thank you. I hope that some of you will have an opportunity to meet. For those who've never been to Zimbabwe, when you come, we've got a beautiful Victoria Falls, nice place for you to check out, as well as the Great Zimbabwe. And this happens to be the capital city of Zimbabwe, Harare, and I stay somewhere over there. Anyway, God bless you. I hope you have fun, and I hope you've got some interesting questions to ask. Otherwise, thank you very much. Bye.